Hello, I'm here with Dr. Stephen Fishbane and Dr. Azur Hazan of North Shore University Hospital Hofstra Medical School to discuss their recent supplement to AJAK-V, update on the quality improvement performance that is coming. Thank you for joining me today.
You're welcome.
Thank you, Kelly.
Thank you.
Thank you. So we'll start. Would one of you mind just quickly describing the three performance measures that are going to be evaluated, actually starting January 1st of this year?
Would you?
Sure. So the Quality Incentive Program, which has been mandated by the End-Stage Renal Disease and is actually part of legislation, has been implemented. It's been in place for a couple of years now, and it's been a successful program by most measures. We have this year 3 reporting measures and 3 clinical indicators that we're looking at. The 3 clinical indicators that are of particular importance to us because it's 90% of the score that's relevant for dialysis centers. One relates to anemia, one relates to dialysis access, and one of them relates to dialysis adequacy, which is the URR measure.
So it's important to mention that this is for the year of 2012 performance, which will be reported in 2014. So it's pay for performance. So 2012 is the year that we're being evaluated on, and it's going to be looked at in 2014, which will affect the payment in 2014. So the 3 core measures, each 30 points, totaling 90%, and there's other 3 reporting measures. One is the adverse events, which the one that is being looked at is the infectious disease aspects of patients on dialysis. The other one is just reporting parameters of mineral bone disease, calcium and phosphorus, without really looking at target goals because there isn't yet, or there isn't agreed upon targets, but just at least checking them monthly. And the third one, which is extremely important, is actually having a survey of the patients, dialysis patients, and look at their experience in the dialysis unit with their providers, and having those 3 will kind of complete the loop, if you will, in terms of the patient's core measures and their reporting to CMS.
So we've got the 3 clinical indicators, which makes up 90% of the score, and then the 3 reporting measures, which together are 10% of the total score.
How many patients are anticipated to be affected when this program starts?
Yeah, so I mean it applies to almost all dialysis patients in the United States, except for those that are very small, and it wouldn't be fair to include some of the very small units. So essentially it could affect care to the extent that dialysis units substantively engage and change their care to try to match the quality incentive indicators. It should impact most dialysis patients' care to one extent or another.
It does seem like a natural progression from the bundling system to start looking at the performance measures and reimburse for centers that do it well. At this point, is it an incentive to do it well for a potential reimbursement, or is it to avoid a penalty?
I think at this point it is a combination of both. Most immediately, it will be to avoid penalty. But I think in the future it's going to be a model where it was going to create an incentive for good performing physicians and dialysis units to link that with performance. I think the idea is, and I think it's more of a global issue rather than only focused on the end-stage kidney disease program. I think in general, as our healthcare evolves, we need to make sure that we deliver the best care to the patients, and one logical way would be to link performance to payments. But that's, I think, at least my feeling is that there will be some immediate penalties depending on how many parameters we meet or we don't meet as a dialysis unit. But I think the idea is to really improve patients' care and performance.
Yeah, and I think, one of the concerns that we've had as a community is that the program is modeled after the hospital-based, value-based purchasing program. And the value-based purchasing program that hospitals use give the opportunity, yes, for the possibility of decreased reimbursement, but it also gives the opportunity for increased reimbursement for hospitals that perform well. And this program for end-stage renal disease is only punitive. You can, at best, maintain your reimbursement, at worst, lose up to 2% of potential reimbursement. So I think that most in the community would like to see the possibility for there to be some reward for a good performance within the program.
I think it stems from the fact that there's very little patients on the Medicare in terms of end-stage kidney disease patients are about maybe 6% of the Medicare recipients or benefactors, but they, the spending of the care, the cost of these patients is not proportional to their very very few patients. So you have 6% of the patient driving the cost by as much as 28%, maybe more. So I think that the idea of having a sustainable system would at least start looking at some ways of linking the two, performance and payment.
That's well said.
So it seems reasonable then that Medicare would choose end-stage kidney disease to look at as a protocol for some kind of quality improvement performance measure, since it's 26% of the budget and 6% of patients.
Yeah, and I think that we, often serve as the guinea pig as they test programs that they're going to roll out elsewhere. And, I guess in this realm, we certainly have been with the program being a couple of years old at this point.
But I think we're good at it as well. Nephrologists are a good quality kind of role model in general, specifically here. But I think it's kind of we're being rewarded for being good. I think quality, conscientious nephrologists. But yes, I think there's a real need on the CMS part of it to contain costs.
What do you think the practicing nephrologist can gain from this program? There's obviously an incentive for the dialysis center itself, and there's obviously a benefit to the patient receiving the best care at the best price.
Yeah.
What about the practicing nephrologist? Is there anything that they can receive from this program?
Yeah, I think for one, to see where they are compared with the national standard of care, to see where they fit. If you talk about a specific dialysis unit, if you look at yourself as a dialysis unit, how are you performing in comparison to the rest of the country? And on that end, if you're doing well, then maybe you could be a role model to the rest of the dialysis units. You could definitely market it as that you're a very good, and other patients and other providers will know that. But also more importantly is to, if there is a problem or if there is a suboptimal performance, then you'll have some lessons to learn and kind of follow suit. Although I think the system is not perfect, we're only looking at there's some kind of deficiencies in the system itself, and the reporting kind of ways can be tricky, but I think in general people will be able to see how they're doing, kind of a national experiment, how we're doing individually compared with the rest of the...
Yeah, and so I think that in addition to the physician quality reporting initiative, which brings us into the realm of reimbursement that's at least partially based on quality, it's easy to see that the QIP for end-stage renal disease could eventually link the physician and the dialysis unit in terms of shared incentives, in terms of how we align our quality goals.
There were some concerns voiced when the bundled payment system was going into effect about dialysis units potentially being influenced to cherry pick the most compliant, healthy patients for their units. It's making it difficult for individuals on dialysis who are not so. Has there been any trend of that happening since the bundle went into effect, or do you see this as another opportunity or influence that may alter that behavior at all?
Yeah, I think it's a really good question, and it's something that we've got to be careful about, including, loss of access to care for people who are potentially high risk. So, if you could separate it into the impact of bundling and the more expensive patient, where the patient who is potentially sicker and is going to require greater doses of, for example, the ESAs, those would be patients that units would be potentially trying to avoid. But I think what we've seen more substantively since the initiation of bundling is patients who are on very expensive antibiotics having a hard time getting out of hospitals and into dialysis units, which is a problem for patients in that it exposes them to falls, to deep vein thrombosis, to nosocomial infections while they remain in the hospitals, and it's probably an unsolved area at this point and an unintended consequence of the bundle. And in terms of the QIP side and how the QIP impacts this, I mean, my opinion would be, and I'd like to see what Dr. Hazan thinks about this, is that the numbers that are at risk are small enough so that when you get to the individual patient level, it's probably not impacting on patient selection and adverse selection as much as the bundle is. But I don't know, do you think that dialysis units are already starting to be affected by the QIP in terms of who they select?
I think you raised two very good points. To answer the last question first, I don't think that the QIP specifically will have as much effect on patients being selected, because this is, if you think about it, you're being encouraged to not overdose on patients' ESA dose. So, in other words, you don't want to give too much ESA, so that's not going to be affecting the bottom line of the dialysis unit. It's a quality that potentially can save dialysis units money. So I don't think that based on financial incentive that the patients will be necessarily punished for not being selected to the, taken into the dialysis unit. But I think about the first point, I think it is a positive, sign that patients are not being in the hospital unnecessarily, where in fact we can bill for their antibiotics in the dialysis unit. But one thing that concerns me about the new guidelines, if you will, about dosing for ESAs is that although we are not being as aggressive in dosing these patients with ESAs to drive their hemoglobin to higher levels compared to the past, I think there is increased, at least initially, in the from initial data, I mean, there is an increase of transfusion, of blood transfusions. So I think it is, bundling, I think, has an effect, and I think it will continue to be, I believe, an evolving effect. I don't think we've seen really what is the ultimate effects yet, because I think some of it is still not in effect.
Yeah, I think that's right. I think, we're in a period of evaluation right now to understand what the both financial and quality impact has been and whether there's any patient safety impact. So it's an interesting period right now in the history of evolution of this.
Well, thank you very much for that. And for some tips and ideas on how to get you and your dialysis center to optimize your performance in relationship to these guidelines, pick up the supplement from AJKD this month with Dr. Azur Hazan and Dr. Stephen Fishbane.
Thank you.
Thank you.